Welcome to our quick reference guide for understanding acid-base balance and arterial blood gases, ABGs. This visual will help you grasp the normal ranges and key components at a glance. Arterial blood gases, or ABGs, are crucial laboratory tests that measure blood pH, oxygen, carbon dioxide, and bicarbonate levels. These tests help diagnose and monitor acid-base imbalances, oxygenation, and ventilation status, especially in patients with respiratory distress. Let's break down the components of ABGs and their normal ranges. pH indicates the acidity or alkalinity of blood. PaCO2 reflects respiratory function. HCO3 shows metabolic function. PaO2 measures oxygen levels, and SaO2 indicates oxygen saturation. Understanding these values is essential for accurate diagnosis. Interpreting pH levels is fundamental. A normal pH ranges from 7.35 to 7.45. Values below 7.35 indicate acidosis, while values above 7.45 suggest alkalosis. For instance, a patient with kidney failure and a pH of 7.30 is experiencing metabolic acidosis. PaCO2 levels are critical for assessing respiratory function. Normal PaCO2 ranges from 35 to 45 mm of mercury. Elevated levels indicate respiratory acidosis, while lower levels suggest respiratory alkalosis. For example, a COPD patient with a PaCO2 of 55 is experiencing respiratory acidosis. HCO3 levels reflect metabolic function. Normal HCO3 ranges from 22 to 26 MEq. Lower levels indicate metabolic acidosis, while higher levels suggest metabolic alkalosis. A patient with prolonged vomiting and an HCO3 of 28 is experiencing metabolic alkalosis. Oxygenation parameters, PaO2 and SaO2, are vital for assessing oxygen levels in arterial blood. PaO2 should be between 80,100 mm of mercury, and SaO2 should be 95,100%. Low values indicate hypoxemia. For instance, a patient with pneumonia and a PaO2 of 70 is experiencing hypoxemia. Interpreting ABGs involves a step-by-step approach. First, assess pH to determine acidosis or alkalosis. Next, evaluate PaCO2 for respiratory function, followed by HCO3 for metabolic function. Finally, determine the level of compensation. This method ensures accurate diagnosis. In this case study, a patient with a pH of 7.28, PaCO2 of 52, and HCO3 of 24 is diagnosed with respiratory acidosis due to hypoventilation from opioid overdose. Symptoms include confusion and lethargy, and treatment involves increasing ventilation and oxygen therapy. Here, a patient with a pH of 7.48, PaCO2 of 30, and HCO3 of 24 is experiencing respiratory alkalosis due to anxiety-induced hyperventilation. Symptoms include dizziness and tachycardia, and treatment focuses on slow breathing and reassurance. This case involves a diabetic patient with a pH of 7.25, PaCO2 of 38, and HCO3 of 18, indicating metabolic acidosis due to diabetic ketoacidosis. Symptoms include Kussmaul breathing and fruity breath, and treatment involves IV fluids and insulin therapy. In this scenario, a patient with a pH of 7.49, PaCO2 of 42, and HCO3 of 29 is diagnosed with metabolic alkalosis due to prolonged vomiting. Symptoms include weakness and muscle twitching, and treatment involves IV fluids and electrolyte replacement. Compensation mechanisms in ABGs are crucial for understanding the body's response to imbalances. Uncompensated means no compensation, partially compensated indicates an attempt to compensate, and fully compensated means normal pH with abnormal PaCO2 and HCO3. This helps in accurate diagnosis. To summarize ABG interpretation, assess pH for acidosis or alkalosis, evaluate PaCO2 for respiratory function, HCO3 for metabolic function, and PaO2 and SaO2 for oxygenation. This comprehensive approach ensures accurate diagnosis and treatment. The clinical application of ABGs is vital for identifying acid-base disorders, recognizing hypoxemia, and evaluating the effectiveness of mechanical ventilation. For instance, a patient on a ventilator requires ABG monitoring to ensure proper CO2 removal and oxygenation. Acid-base balance is the regulation of hydrogen ion concentration in body fluids to maintain homeostasis. The normal pH range is 7.35 to 7.45. For example, a patient with sepsis may develop metabolic acidosis due to increased lactic acid production. Understanding pH is crucial for maintaining homeostasis. pH measures hydrogen ion concentration, with lower pH being acidic and higher pH being alkaline. Normal pH ranges from 7.35 to 7.45. A patient in shock with a pH of 7.25 indicates acidosis due to poor tissue perfusion. Buffer systems help maintain pH stability by neutralizing excess acids or bases. The main types are bicarbonate, phosphate, and protein buffer systems. For instance, the bicarbonate system reacts with excess hydrogen ions to prevent dangerous pH changes. The lungs play a crucial role in acid-base regulation by controlling CO2 exhalation. Normal PaCO2 ranges from 35 to 45 millimeters of mercury. For example, a patient with COPD who retains CO2 may develop respiratory acidosis, indicated by a pH of 7.28 and PaCO2 of 50. The kidneys maintain acid-base balance by excreting hydrogen ions and reabsorbing bicarbonate. Normal HCO3 ranges from 22 to 26 MEq. A patient with kidney failure who cannot excrete hydrogen ions may develop metabolic acidosis, indicated by a pH of 7.2 and HCO3 of 18. Arterial blood gases, or ABGs, measure blood pH, PaCO2, and HCO3 to assess acid-base status. Normal values are pH 7.35-7.45, PaCO2 35-45 millimeters of mercury, and HCO3 22-26 MEq. For example, a patient with a pH of 7.30, PaCO2 of 50, and HCO3 of 24 is experiencing respiratory acidosis. Respiratory acidosis occurs when CO2 retention lowers pH below 7.35. It can be caused by conditions like COPD, respiratory depression, or airway obstruction. For instance, a post-surgical patient with shallow breathing may develop CO2 retention, resulting in a PaCO2 of 50 and a pH of 7.28. Respiratory alkalosis happens when excessive CO2 loss increases pH above 7.45. This can be due to hyperventilation, anxiety, or fever. A patient experiencing a panic attack might have a pH of 7.48 and PaCO2 of 30 due to hyperventilation. Metabolic acidosis is characterized by a decrease in HCO3 below 22 MEq, leading to an acidic pH. Causes include diabetic ketoacidosis, kidney failure, and lactic acidosis. For example, a diabetic patient with high ketones may have a pH of 7.25 and HCO3 of 18, requiring bicarbonate therapy. Metabolic alkalosis occurs when an increase in HCO3 above 26 MEq, leads to an alkaline pH. This can be caused by prolonged vomiting or diuretic use. A patient with persistent vomiting might have a pH of 7.48 and HCO3 of 28 due to loss of gastric acid. The body tries to restore pH through respiratory or renal compensation. There are three types: uncompensated, partially compensated, and fully compensated. For instance, a patient with metabolic acidosis and a pH of 7.28 may compensate by hyperventilating, resulting in a PaCO2 of 28. The anion gap helps differentiate the causes of metabolic acidosis. A high anion gap can indicate conditions like diabetic ketoacidosis or lactic acidosis, while a normal gap might suggest diarrhea or renal failure. For example, a septic patient with high lactate may have a high anion gap metabolic acidosis with HCO3 of 14 and an anion gap of 18. In diabetic ketoacidosis, the pH is less than 7.3, HCO3 is low, and there is a high anion gap. Symptoms include Kussmaul breathing and fruity breath. A diabetic patient with DKA might have a pH of 7.25 and require IV insulin and fluids. Chronic CO2 retention in conditions like COPD can lead to respiratory acidosis, characterized by low pH and high PaCO2. Symptoms include confusion, lethargy, and cyanosis. A patient with a COPD exacerbation might have a PaCO2 of 55 and require BIPAP support. Hyperventilation can cause respiratory alkalosis due to excessive CO2 loss, leading to high pH and low PaCO2. Symptoms include dizziness, paresthesia, and tachycardia. A patient with an anxiety attack might have a pH of 7.50 and be treated with rebreathing techniques. Prolonged vomiting can lead to metabolic alkalosis by increasing bicarbonate levels, resulting in high pH. Symptoms include weakness and muscle twitching. A patient with excessive vomiting might have a pH of 7.49 and require IV fluids and potassium. Key concepts include normal pH ranges, acidosis, alkalosis, and the respiratory and metabolic factors involved. For instance, metabolic acidosis with respiratory compensation can be seen in severe diarrhea cases. Applying ABG interpretation and understanding acid-base balance is crucial in patient care. Recognizing mixed disorders and compensation mechanisms can prevent severe complications. Early recognition of acid-base imbalances is vital in critical care settings. If you found this content valuable, please subscribe, like, and share to stay updated. Your engagement helps us grow and provide better resources. For questions or struggles, drop a comment or email us at nclexmap@gmail.com. We're here to help.